Welcome back to this next video in which we are discussing cardiac arrhythmias. Okay, so we've just been talking about ventricular ectopic beats and the mechanism by which lidocaine, or lignocaine as it can also be called, can be used to prevent the signals that are being generated by these ectopic foci from actually spreading to the entire myocardium. And the way that this works is that it causes cardiomyocytes that are being stimulated to generate action potentials at too high a frequency from conducting action potentials whatsoever. And this, by the way, is the same reason that lidocaine is effective as a local anesthetic and as a anti-epileptic drug. In the case of being a local anesthetic, primary afferent nociceptive neurons, pain neurons, that are being stimulated by noxious stimuli are being stimulated to fire action potentials at ridiculously high rates, much higher rates than other neurons, other sensory neurons that are for non-pain modalities would be stimulated to fire action potentials. Lidocaine, therefore, will stop those pain neurons from firing action potentials whatsoever, and that's how it stops signals coming up the pain neurons, but then not other neurons that are relaying information about other sensory modalities, and even neurons that are sending information out to the periphery rather than taking it up. Okay, so that's the basis of why lidocaine can be used as a local anesthetic. For epilepsy, in epilepsy, of course, what happens is somewhere in the brain an epileptogenic focus is formed, which is basically the same principle as an ectopic focus in the heart, but instead in the brain rather than in the heart. So somewhere within the brain, an epileptogenic focus is produced, and this starts chucking out electrical signals at ridiculous rates. And again, if you give lidocaine, what will happen is the neurons surrounding the epileptogenic focus, they will now not fire action potentials at all because they're being stimulated to do so by the epileptogenic focus at far too high a rate. That will prevent all of those electrical signals coming from the epileptogenic focus from spreading to whichever portions of the brain they were spreading to previously. Okay, whereas of course it won't stop the neurons all over the brain that are conducting action potentials at a perfectly reasonable rate from conducting action potentials, even though the drug will continuously be blocking the voltage-gated sodium channels in those neurons, just the same as it would be the neurons surrounding the epileptogenic focus. But because they have that reasonable interval between their neighbouring action potentials, it doesn't matter. You have time to get the drug off the voltage-gated sodium channels in time for the next action potential. Okay, right. So now moving away from that, let's now talk about the terrifying arrhythmias of ventricular flutter and ventricular fibrillation. And this shouldn't take too long because it's the same mechanisms as for atrial flutter and atrial fibrillation, except that now it's more terrifying because it's occurring in the ventricles, and this is going to lead to ridiculously high levels of ventricular contraction, which is extremely dangerous and can lead to cardiac arrest. Okay, right, so let's start off with what's going to happen in ventricular flutter then, and then we'll go on to ventricular fibrillation. So just like in atrial flutter, hopefully you can recall atrial flutter, the mechanism for ventricular flutter is going to be that we're going to have some re-entrant loop somewhere in the wall of one of the ventricles, so either in the right ventricle or the left ventricle, somewhere we're going to have a ring that a circus rhythm is going to establish around, and this ring could be because of some damaged myocardium. It's usually because you have had a myocardial infarction that has resulted in a whole bunch of cardiomyocytes dying and being replaced with a scar, which obviously isn't conductive, and then what can happen is you can get circus rhythms establishing around that piece of scar tissue. So I'll just draw a picture of this. So let's say this is our piece of scar tissue here, so I'll just colour it in blue. So here's our scar tissue. Then of course you have the possibility potentially of getting a circus rhythm going round this loop here, and then of course it will just continuously regenerate itself, and all the time it'll be throwing the electrical signal off to the neighbouring cardiomyocytes, and it will therefore be propagating over the entire ventricles and then up to the atria through the conduction system. Okay, so let's start off by talking about what the what the ECG is going to look like in the case of ventricular flutter. Well, generally what it ends up looking like is a sinusoidal wave. Okay, of course this will depend on the position of the reentrant loop. If it's right down at the bottom of the heart, then what you would imagine is you'd get retrograde conduction up the ventricles and then retrograde conduction up the atria as well, so you'd imagine that it would just look like a massive downward deflection. But if you think about that, that will still end up looking like a sinusoidal wave. So let me just get a picture of the heart back up so that I've got a picture to point at. I was trying to find another picture from my previous notes, but I'll just draw the picture again. So here let's have the right atrium here, and then we'll have the ventricles here, right ventricle and left ventricle. Okay, so if this reentrant loop then was right down at the bottom here, then it will be throwing electrical signals off upwards, and then the electrical signal will be propagating up the ventricles, and of course that would mean that the wave of depolarization propagates retrogradely. In addition, the electrical signal would propagate up the ventricular conduction system, up the AV node and up to the atria here, and again would propagate up the atria retrogradely. So what we'd actually end up with is something that looks like this. We get a massive deflection downwards here, which is ventricular, and most likely atrial at the same time, depolarization, because remember, the ventricular conduction system is very fast, so it would get it up to the AV node reasonably quickly, and then, yes, okay, the AV node's slow, but it would sort of get up to the atria reasonably quickly. Okay, so it's likely that you'll be getting ventricular spread whilst you'll be getting atrial spread as well. So this massive great downward deflection would be both ventricular and atrial spread of the electrical signal. And then of course what would happen is it would go around again, so it would now go round again like so, and you'd end up with this sort of stretched sinusoidal wave, and this is generally what the ECG pattern does end up looking like for ventricular flutter. Okay, so even if the reentrant loop is in a different position, so let's say now it's at the top of the ventricles, then of course you get anterograde conduction and then retrograde conduction up the atria as the electrical signal propagates up the ventricular conduction system. But really, even though you have got the retrograde conduction up the atria, you don't usually actually see that, because of course atrial depolarization is minor compared to ventricular depolarization, and they'll be occurring generally on top of each other, because even if, well, let me explain this in a bit more detail. Let's say we do have a reentrant loop here, okay, right at the top of the ventricles here. Then the electrical signal will firstly propagate down the ventricles, and then it will be propagating up the ventricular conduction system and up to the atria. Okay, so you might say, well, obviously then atrial depolarization is after ventricular depolarization, so surely you'd get a wave for ventricular depolarization and then a wave for atrial depolarization. But you don't generally see the wave for atrial depolarization, because by the time it's got to the atria, you're already getting another wave of ventricular depolarization. So generally, really, on these ECGs for ventricular flutter, it does just look like this. And now the isoelectric line might be up here or it might be down here, depending on the position of the reentrant loop. If the reentrant loop was down here, of course it would be a downward deflection, and this would be the isoelectric line. If it was up here, then you'd expect an upward deflection, and this would be the isoelectric line down here. But the ECG generally does look like this sinusoidal structure, this sinusoidal wave here. Okay, so that's what the ECG then is going to look like in ventricular flutter, and the number of times the ventricles end up beating can actually get up to 300 times per minute. Now this is of course extremely dangerous, because at that sort of rate, the ventricles are not going to have time to relax back down after each beat. So what will be happening is they'll be in a permanently contracted state, and they'll only have a tiny bit of relaxation before they then beat again. So cardiac output will be hugely down, stroke volume will certainly be down, and even with the massive rate at which the stroke volume is being ejected, because of course we are, you might say, well yes, okay, the stroke volume with each beat has gone down, but we're doing it 300 times a minute, so surely that will help boost the cardiac output overall back up. Well, the massive rate doesn't really compensate for the huge drop in stroke volume with each beat. So overall cardiac output does drop considerably, and we're approaching what would be called cardiac arrest, and indeed with ventricular fibrillation you do get cardiac arrest. So I just want to define what is meant by cardiac arrest to make sure that everyone's clear with this concept. So cardiac arrest is when the heart fails basically completely. Okay, it fails to actually pump any blood around the body basically. That is what cardiac arrest means. It means that the heart is no longer actually beating blood out into the pulmonary trunk and the aorta. Now it does not mean that there is absolutely no electrical activity in the heart. In ventricular flutter and ventricular fibrillation there is going to be a huge amount of electrical activity in the heart. Contraction is going to be occurring all the time. Okay, so it doesn't mean that the heart isn't contracting, it means that there isn't actually any blood being ejected from the heart. So cardiac arrest means that the actual job of the heart has arrested. Okay, it's not actually occurring anymore. The actual job of the heart is of course to pump blood around the body. You're not getting any blood pumped around the body, and of course this is extremely dangerous. It's then just a race which dies first, the heart or the brain, when no blood is being pumped to them. Okay, so it's a medical emergency, a cardiac arrest. Okay, so ventricular flutter, generally that's not quite bad enough for you to be in cardiac arrest yet. Okay, you will still have a bit of blood going around the body. Of course, it will be far too little generally, but it will still be enough to sustain you. What can now happen, however, is ventricular flutter can often descend into ventricular fibrillation. So now let's go on to the really dangerous one, which is ventricular fibrillation, and we'll talk about the treatment for both ventricular flutter and ventricular fibrillation afterwards. Okay, so ventricular fibrillation then. So in ventricular fibrillation, just like in atrial fibrillation, the number of electrical signals that the ventricles now are actually receiving every minute can go up to 500, and therefore the atria. Sorry, I keep wanting to say the atria. The ventricles can end up beating at a rate of 500 times a minute, contracting at this rate of 500 times per minute. And just like with atrial fibrillation, ventricular fibrillation is generally caused by having multiple reentrant loops and multiple ectopic foci. So reentrant loops and ectopic foci together in the walls of the ventricles, creating electrical signals all over the place. So you get loads and loads of electrical signals being delivered to the ventricles all the time, and this can stack up to this impressive level of 500 beats per minute. Okay, right, so what's the ECG then going to look like for ventricular fibrillation? Well, it looks hideous. The reason is that the different ectopic foci and the different reentrant loops which are generating these electrical signals can be in loads of different positions all over the ventricles, and therefore the direction in which the wave of depolarization is going to spread can continuously be varying depending on where the electrical signal has actually originated from. So ventricular fibrillation, what I will draw is something that looks like this. Okay, so the ECG will just look absolutely crazy if you're in ventricular fibrillation. So this is generally what ventricular fibrillation looks like, a complete mess, because the electrical signal is continuously changing the direction in which it's propagating, because it's continuously coming from a different area. So the cardiac vector is all over the place basically. Okay, so this is of course extremely dangerous because the ventricles aren't really actually going to be contracting and relaxing at all. Instead, what happens is they just stay in a permanently contracted state and they sort of shudder. Okay, they sort of try to relax, but the instant they try to relax they're then forced to contract again, so they just sort of shudder in the permanently contracted state, and no blood is actually being pumped into the pulmonary trunk in the case of the right ventricle, or into the aorta in the case of the left ventricle, and therefore you have gone into cardiac arrest, and that's a medical emergency. So ventricular fibrillation usually causes cardiac arrest. Okay, so how then do we treat ventricular flutter and ventricular fibrillation, in particular ventricular fibrillation? Well, we can use what's called a defibrillator. So it's a medical emergency, and what often happens is it's treated with a defibrillator. So I want to go over what a defibrillator is and how this is actually going to help. So of course the name of this means let's take you out of ventricular fibrillation, defibrillator. We're going to end ventricular fibrillation. Okay, and the principle is this. We are going to send a huge great current through the heart to totally reset the heart. So what you do is you generally have your person lying down, having their cardiac arrest here. So let's say this is their chest here, so I'll just have put some limbs on here. And what happens is you have these paddles. Okay, so you put on one paddle here, and these are sort of handled paddles. If you've ever used, what are they called? Those things for doing press-ups to stop it hurting your hands. So you can get sort of like stilts for doing press-ups. I don't know what they're actually called. But you put them on the floor and then you put your hands on them. In fact, I'll draw a little picture. It won't be too difficult. So they look kind of like this. So this is what these things for doing press-ups look like. You have a bit that you put on the floor, and then you sort of obviously hook your hand around this handle here, and then you can do your press-ups on there. Well, actually the paddles of the defibrillator look extremely like this. So they have handles, and then the bit that's equivalent to the portion that will go on the floor, in the case of these press-up assistants, are the actual electrodes that are going to go on the chest. So you put the two paddles of the defibrillator over the chest here, and then the idea is you're going to create an electrical potential difference between the two, so that current can now flow between the two. Okay, so you're going to create an electrical potential difference between the two, and current is going to flow through the body, and of course we position these so that it's going to flow through the heart. Usually you put the paddles on the front of the chest in this way, and then the current's going to flow through the heart. You could alternatively put one paddle on the front of the chest and then one on the back. The idea is you just need the current to flow through the heart, so you need to have one on either side of the heart. This is the way it's normally done, but if you can put them on either side of the body, that would do it as well. Okay, so you put the two paddles on the chest like so, you create an electrical potential difference between the two, a massive current then flows through the heart, which is why defibrillators are often referred to as shocking, or they deliver shocks. We say we're going to shock someone. That's a sort of colloquial way of saying we're going to use a defibrillator on them. Okay, and this resets the heart completely. So we deliver a massive great current through the heart, and all electrical signals in the heart are killed. Okay, so all of these re-entrant loops, all of these circus rhythms, all of the ectopic beats, they're all killed. All of the cells go back to being in the, well, they initially go into the depolarized state when the electrical current is actually passing through the heart, but then after you remove the electrical current, you turn your defibrillator off, all of the cells are going to go back into the resting state, and then the hope is that the sinoatrial node cells will then say, right, let's begin again, let's open our HCN channels and generate an electrical potential difference across the cell membrane, generate an action potential across the cell membrane, and the electrical signal will then propagate from the sinoatrial nodes. So the idea is, with a defibrillator, that you completely reset the heart, and the hope then is that the sinoatrial node will then go back to driving the entire electrical activity in the heart, and you'll return to normal sinus rhythm. And it does work reasonably well. Of course, you can descend back into ventricular flutter and ventricular fibrillation because, you know, it doesn't get rid of these re-entrant loops that have the potential to drive circus rhythms. It doesn't solve the problem of all of those ectopic foci in ventricular fibrillation, which for some reason had the ability to generate spontaneous electrical signals. But at least for a while it does reset the heart, and hopefully you'll go back to normal sinus rhythm. Okay, now in people who are extremely prone to ventricular flutter or ventricular fibrillation, you can actually have implanted defibrillators which will do this, deliver an electric shock through the heart whenever you go into ventricular fibrillation, so that you don't have to be in hospital with someone capable of doing defibrillation every time it occurs. Okay, right, so that is ventricular flutter and ventricular fibrillation, which are usually treated with a defibrillator. What we're going to do now is we're going to have a break, and then in the next video we're going to talk about the last ventricular arrhythmia that I want to discuss in this video, which is Torsades De Pointes. After that we'll then go on to discuss AV block and bundle branch block.